Hello and welcome to the Echo by Web YouTube channel. It is a channel for professionals, mainly cardiologists and sonographers, but not only, dedicated to the world of echocardiography. The aim of this channel is to provide the basic physiopathology and methodology which are necessary to both understand and perform and interpret a complete echocardiographic examination. This channel will deal with many of the topics that we all have to engage with in daily practice. Valvulopathies, cardiomyopathies, systolic and diastolic function and dysfunction, and also the new technologies like left ventricular systolic strain analysis. My name is Paolo Barbier. I am broadcasting from Italy. I am a cardiologist with a special interest in imaging and echocardiography, and I will guide you through clinical cases and talks from my clinical experience addressing a wide range of echocardiography topics. My imaging, the images that you will see in my talks, are all based from my experience in Italy and in northeast China, where I have worked for about 5 years. Echo by Web is not only a YouTube channel, it is also a website, echobyweb.com, where you will find much of the materials I will present you in this channel. So let's have a look. This is the homepage of the website, echobyweb.com. Up here in about, you will find my credentials. Under Atlas, you will find 2 atlases of imaging, transthoracic and transesophageal. It's work in progress. Under Ecolab, you will find normal values for echocardiography, scores like the Wilkins scores, the Montgomery plaque classification, and analysis and quantification of the left ventricle, the mitral valve. And then you will also find formulas and calculations, guidelines, references, an example of a complete echocardiographic examination. You will also find here online calculators, which are Excel spreadsheets on the website with which you can interact, and you can make a lot of calculations, stroke volume through the valves, and you can find the indications for valve surgery based on the latest guidelines, European guidelines, and you can find also flowchart for the calculation of diastolic function from the latest recommendations. And this is the QR code with which you can access, for example, if you have a cell phone. The topic of this talk, which spans over 5 videos, and this is the 4th video, is the echocardiographic analysis of left ventricular systolic function and dysfunction as seen in the real world. This is, of course, a basic approach to the topic, which is quite large. Now, these talks assume that you have a basic understanding on how to perform post-Doppler and continuous wave Doppler interrogation of intracardiac flow, how to make 2D measurements, and how to use myocardial tissue Doppler. It also assumes that you know to perform the basic echocardiographic measurements. However, as mentioned before, you can refer to the echobyweb.com website for a large quantity of teaching material that address these topics. And this is the outline of this talk on left ventricular systolic function. We begin with an introduction and definitions. Then we move on to physiopathologies and define the determinants of systolic function. We analyze the pressure volume loop as constructed invasively, and we see how invasively we define left ventricular contractility. When we move on to the aims and the qualitative evaluation of left ventricular systolic function, and then the mechanical function of the left ventricle through ejection fraction, and how to perform stroke volume assessment and cardiac output. And then we have the echocardiographic estimation of left ventricular contractility using isovolumic phase indices like the noninvasive dP/dt from mitral regurgitation and the myocardial performance index or TEI index. And we end with the analysis of left ventricular longitudinal function using tissue Doppler, because strain analysis will be the topic of a whole new another video. And these are how they are grouped in the 5 videos. This is video number 4, talking about left ventricular mechanical function and specifically how to measure stroke volume and cardiac output. These are the determinants of stroke volume. We begin with the determinants of myocardial shortening, which are preload, afterload, as we already talked in the previous slides on physiopathology, and myocardial contractility. Stroke volume is then determined by myocardial fiber shortening and left ventricular preload, which is left ventricular and diastolic volume. Cardiac output is the product of stroke volume by heart rate and output together with peripheral vascular resistances produces arterial blood pressure. The normal value for stroke volume index is 40 to 60 milliliters per square meter. As I mentioned previously, in my opinion, the most accurate method to measure stroke volume in echocardiography is with pulse Doppler flow. Now, the flow volume Q up here in this panel equals V, the mean velocity of blood flow sampled with pulse Doppler at the same location here, for example, where we measure A, which is the section area of the vessel. When measured in systole, without regurgitations, in the left ventricular outflow tract, for example, we have left ventricular stroke volume. If we measure this at the outflow, the right ventricle, for example, we have right ventricular stroke volume. And cardiac output is the product of Q, the stroke volume, by heart rate. The measurement of stroke volume with echocardiography and pulse Doppler is accurate, but a proper methodology must be followed. So to obtain stroke volume, we need the velocity time integral, this one, of the pulse Doppler of left ventricular outflow, and the outflow tract area, which must be measured at the same location where the velocities are sampled, so at the outflow tract. Now, the area that we measure is that of the distal part of the outflow tract, as in C and D below, in this below panel here, in the parasternal long axis view, immediately upstream of the aortic annulus, which is immediately below the insertion of the annulus, of the anterior right coronary cusp and the posterior non-coronary cusp. So you position your caliper for measurement just at the annulus, just below here, the cusp, here and here, or in this other example, here and here, and you have two diameters, 1.9 centimeter here, 2.3 here. In transthoracic echocardiography, we assume that the annulus is circular, which is a fair assumption for the purpose of measuring stroke volume. And therefore, we measure only one diameter, like here, in the parasternal long axis view. So we measure the anteroposterior diameter. The area of the outflow tract is then obtained by squaring the radius and multiplying by Greek pi 3.14, or by directly, this is faster, squaring the diameter that we measure directly and multiplying by 0.785. The velocity time interval that you see here, by staying on the outer part of the integral, is obtained in the apical 5-chamber view, as we see in this panel A, using color Doppler first to visualize the outflow. It is essential to identify the correct positioning of the pulse Doppler sample volume, which is this black circle here, as in this panel. The sample volume should be positioned looking at two things. One is directly just preceding the annulus, just upflow to the annulus, and away from the angular acceleration here near the angle of the septum, so a little bit more close to the anterior mitral leaflet, where you see the color Doppler is between the blue, yellow, and orange, when we have set a liaison velocity between 45 and 65. Again, it is important when measuring stroke volume to position correctly the sample volume shown here in the panel A and here in panel C. It is very important to avoid the proximal acceleration that you can see here near the proximal part of the interventricular septum in the 5-chamber view. So when you have this angular acceleration, the sample volume should be positioned nearer the mitral valve as here. Okay, because in this case you would measure higher velocities, which would make a larger stroke volume, incorrectly larger, would be oversampled. For example, in this case you would have 23.8 centimeters of velocity time interval, whereas the correct number will be 20.5. So here you overestimate stroke volume. And the other thing is that when you do the velocity time integral, when you do the planimetry of it, you have to stay on the outer border of the velocity, you see, a velocity spectrum, okay? Not too far away, not on the inside, just on the outside. And this is another example of overestimation, which is probably the most frequent pitfall in this case. Up here, the position of the sample volume is too medial near the septum. We have 28.9 centimeters. Down here, the correct positioning, you have 24.6. Okay, and the other thing here is that it is important to have a maximized VTI. This is too small. This is probably the best, and to have a nice outer border, and the velocity time spectrum should not be hazy. You should well see well the band, the narrow band of the spectral velocity. And once you have your velocity time integral of LV outflow and you have your outflow diameter, you multiply velocity time integral by the area of the outflow. If you multiply by the heart rate you have at that moment, then you obtain cardiac output. And here we have two examples of measurements. On the left panels we have normal stroke volume in a normal subject, and on the right panels we have reduced output in dilated cardiomyopathy. And you can see the normal subject has a stroke index of 55.3 milliliters per square meter. Stroke index is stroke volume divided by the surface area, and that is the measurement we use. And on the right here, the reduced stroke volume, stroke index of 30.6 milliliters per square meter. Remind you that the cutoff, the lower part of normal is 35 milliliters per square meter. In this example, the outflow tract, the diameter is very similar between the two patients, 2.36 centimeters in a normal subject, 2.41 centimeters in the patient with dilated cardiomyopathy. So the difference in stroke volume and stroke index is made just by flow. Otherwise, you can have a difference because, for example, the integral is the same, but you have a very different outflow tract area. Typically, in every machine, once you enter the diameter of the outflow tract, the machine calculates automatically the area of the outflow tract, and once that you input the velocity time integral, once that you measure it, the machine gives you immediately the stroke volume, and if you have entered patient body weight and height, it will calculate body surface area, of course, and give you the stroke volume index. So it is very important that when you input the demographics of the patient that you should always input in your machine, you always also input body, the weight and height, so that you have body surface areas, because most measurements in echocardiography we use index values, so to compare them between patients, and we really need the stroke volume index. You could also not measure the outflow tract area and just evaluate the velocity time integral. It is not the best method because that is not very precise, but generally speaking, if you have velocity time integrals higher than 15, they are normal, and less than 15, probably they are reduced. But again, it is better to have the exact measurement of stroke volume index. For example, in some cases, you really need to know if you are over or below 35, which is the cutoff, the lower value for normals. There is another location where you can measure stroke volume on the left side of the heart, and that is the mitral valve area, the mitral valve annulus. The methodology is similar. The pulse Doppler flow is sampled at the level and in the middle of the annulus, as shown here in panel A, and the velocity time integral is obtained. Next, the annulus is measured just below the insertion of the mitral leaflets on the annulus, as in panel D, and you use the 4 and the 3 chamber view because you need to measure the maximum mediolateral annulus dimension and the minimum anteroposterior annulus dimension. And this is because in normal subjects you have an oval geometry of the annulus, and so you use this formula here to calculate the area of the oval, whereas only in dilated cardiomyopathies you may have an altered geometry of the annulus, which is not an oval anymore, but it's circular. So again, the pulse Doppler is positioned, the sample volume, just in the middle of the annulus. It is very important not to stay in the ventricle or in the atrium, but just in the middle. So because the base of the heart, the annulus, shifts toward the base in systole and comes back in diastole, and we want to measure flow in diastole, we have to wait for the annulus to come back to its baseline position. So you have to pay attention at sampling during diastole, okay, and in the middle of the annulus. You then perform the planimetry on the outer part of this narrow band here of the spectral velocity. You average, it's better to average at least 3, even though the patient should be asked not to breathe during this operation. And once you have the velocity time, you move to the matrilus annulus area measurement. You need at least 2 measurements, and if you apply the formula for the oval, so it's Greek pi 3.14 multiplied by the major annulus divided by 2 and multiplied then by the anteroposterior annulus divided by 2. The anteroposterior annulus is in the 3-chamber view, whereas the maximum annulus could be in the 4-chamber view, but it could also be in the 2-chamber or in between. So it's, if you need a precise measurement, for example, if you need to have a precise stroke volume through the mitral valve, and you want to compare it with a stroke volume through the aortic, through the outflow, so to calculate the regurgitant volume, for example, in mitral regurgitation, and then you have to search for a precise maximum diameter between the 4 and 2-chamber and the 2-chamber view. Now, unfortunately, in the current guidelines, I think both American and European, it is stated that you can measure stroke volume at the mitral valve level by simplifying and assuming a circular orifice of the annulus, the mitral annulus, and so measuring only this medial lateral diameter and then applying the formula for the circular annulus area. Unfortunately, this is very incorrect because in most patients that still have an oval geometry, by applying a circular formula, you will greatly, in some cases very greatly, overestimate stroke volume. So the measurement would be very imprecise and totally not useful if you have to measure the mitral valve regurgitant volume or regurgitant fraction. So don't do this, and I really don't understand why this is stated in the guidelines. Now, stroke volume can also be measured using 2D volumes. You see here 2 views, in the apical views, and in the 4 and the 2-chamber view, in which shows the calculated monoplane stroke volumes. Okay, stroke volume in 2-chamber view, stroke volume in 4-chamber view, and then the machine anyhow applies the biplane stroke volume and stroke volume index. But as I said previously, I think that this methodology is far less accurate than using the pulse Doppler stroke volume that we just described, The problem here is that very frequently you underestimate the stroke volume. And finally, we can measure stroke volume using 3D volumes. In this case, it's much more accurate than the 2D measurement, and you obtain as a bonus with all the softwares also a nice curve of the volume during the cardiac cycle. And of course, you need to have the technology available, and you need to pay attention that the software doesn't make errors like in this case here. But it is accepted as a very accurate way to measure stroke volume that correlates with the measurements made with MRI. And these are the normal values from my former Echo lab, the normal values and the mean standard deviation and the 95% confidence interval. And you have this for the LV outflow tract, the velocity time integral, and then you have stroke index, cardiac index, and below you also have for the same population, the same as the previous slides, the 2D stroke index and cardiac index. Now here you can see that the averages, pulse Doppler and 2D in the same population are substantially identical. But still, don't be confused. As I said before, although the averages in the population are equal, in the single patient you tend to underestimate this value in a few patients. And then we have here 3 examples of stroke volume calculation and cardiac index in 3 patients. A normal subject here on the left, hepatic cirrhosis here in the middle, and dilated cardiomyopathy on the right. And compared to a normal subject, you can see the patient with cirrhosis here has a preserved cardiac output, 5.6 liters per square per minute against 5.9, due mainly to tachycardia in a patient which has a reduced preload and diastolic volume, 64 milliliters against 106 on normal subject. Almost similar area of the outflow tract, substantially reduced VTI of the outflow tract, and the output is maintained in this case by tachycardia. And then here on the right we have a patient with dilated cardiomyopathy, a greatly increased diastolic volume or preload, normal area of the outflow tract, greatly decreased cardiac output. We have a decreased VTI, and we also have bradycardia, which exaggerates the reduction in stroke in a cardiac index, in cardiac output as shown here. Also note here in the patient with dilated cardiomyopathy that the velocity time integral is quite small, especially in relation to the increased diastolic volume. Supporting the evidence of the importance of the echocardiographic measurement of stroke index is this analysis, which it was conducted in a cardiac care unit, intensive cardiac care unit. The authors studied the association of selected echocardiographic variables with hospital mortality or multivariate logistic regression when entering into the model individually the variables or in combination with other predictors, echocardiographic predictors. And the authors stress here stroke volume index, which is the best predictor of hospital mortality. Do you see the cutoff value here of 35 milliliters per square meters? This value is worth remembering because it is also present in several guidelines to define the lower cutoff for a low stroke volume, low flow situation. For example, in the guidelines for the management of aortic stenosis. And this relation of between cardiac output, stroke index, and mortality is independent of ejection fraction. In our patients, generally, a reduction in stroke volume should be of greater concern than a reduction of ejection fraction, as we have mentioned before. Stroke volume correlates more with the symptoms and New York Heart Class Association often than ejection fraction alone. So we have established that cardiac output and stroke volumes are important, but how accurate and reproducible is this measurement with echocardiography? This other study, like many others, this is one of the most recent, it's from 2017, tells us that measuring left ventricular stroke volume cardiac output using echocardiography is accurate. And this is a specific case of clinically ill patient where the echocardiographic tool is when it's most useful in intensive care unit. And you can see in these two graphs, on the left, absolute measurement of the output, on the right, changes in cardiac output. You can see here that around the lines of identity, the dispersion of the measurements comparing transthoracic evaluation on the vertical axis and invasive evaluation of cardiac output on the horizontal axis. As I said, the dispersion of values is quite limited. So in the end, the echocardiographic measurement is quite accurate. Again, considering accuracy and reliability of echocardiography, in this case, this is measurements made in my former echo lab comparing the transthoracic echocardiography, pulse Doppler and 2D with MRI. Now, it's quite common to consider echocardiographic measurements, both stroke volume and the volume by itself, less precise, less reliable than those obtained with MRI. But I think that this consideration may not be entirely accurate. Let's see. So we are comparing in these different graphs that we will now see in sequence measurements done in the same patient with echocardiography and shortly afterwards with MRI. And starting with panel A, the graph in A, we have here on the horizontal axis Doppler, pulse Doppler evaluation of stroke volume with the left ventricular outflow tract, as we have seen the methodology before. And on the vertical axis, we have the same evaluation with MRI, on the aortic MRI, on the outflow tract. Now, there is a fair amount of variability along the identity line, and this is explained usually, commonly, because of a lower accuracy of pulse Doppler evaluation, and generally of the echocardiographic examination. But is this really the case? Now, looking panel B, we have a comparison between two measurements done with MRI. On the horizontal axis, aortic level, the same stroke volume, same patient. In the vertical axis, pulmonary level, perfect accuracy with the two methods in the same patient, and there's no problem there. But then look at C. In C, we have transthoracic evaluation with pulse Doppler of stroke volume in the same patient. Horizontal axis, we have stroke volume evaluated at the outflow level and left ventricular outflow, and on the vertical axis at the mitral valve level. We have just seen in a previous slide how to do that, and the correlation is excellent, exactly as with MRI. But if both methods correlate optimally one with each other, as in B and C, then why do we observe this variability here when we compare one method with the other? That's because each method has anyhow a slight variability within itself. Here MRI and here pulse Doppler echo. So when we compare the two methods one with the other, CMRI with pulse Doppler echo, we multiply the variabilities. And that's why here the cloud of points gets larger. And finally, graph E here on the lower left gives us another piece of information. I've mentioned this before. We compare here in the same patient on the X of the horizontal axis pulse Doppler evaluation of outflow tract stroke volume, and compare it with the 2D evaluation of stroke volume done with the volumes. As I said before, we can see here that there is a fair amount of underestimation of stroke volume with the 2D method compared to the pulse Doppler stroke volume. And if you compare this with the same MRI situation, you can see that this does not occur with MRI. We have seen in a previous slide that the left atrium expands during ventricular systole when receiving venous flow from the lungs, and by expanding displaces anteriorly the aortic root. Let's consider now the relation between left atrial filling, the left atrial reservoir phase during ventricular systole, and left ventricular stroke volume. Let's look first at the filling of the left atrium. Now, note how this normal atrium here, you can see how it expands during systole. So here in A is end-diastole, here is systole of the ventricle, and here you have the expansion of the atrium in the four-chamber view, and the right panels here, diastole and systole, ventricular diastole and ventricular systole, and you can see how the atrium expands. The expansion, the reservoir expansion of the left atrium is shown by the blue arrows here in the four-chamber view and here in the two-chamber view. We have an expansion towards the left ventricle in systole because the annulus, the cardiac base, moves towards the apex of the left ventricle, and this is called the systolic descent toward the apex of the cardiac base, which of the cardiac base toward the apex, and the apex is fixed on the diaphragm. And this is related also to the contraction of the longitudinal fibers of the left ventricle, longitudinal fibers that pull down the base of the heart. We will see this shortly. The systolic expansion of the left atrium also occurs through the movement of the interatrial septum towards the right atrium, and we have also an expansion here laterally. There is, however, no expansion of the left atrium superiorly, because here we have the spine and the aorta, which are fixed. So the superior wall of the left atrium up here, you can see, is fixed between the left upper pulmonary vein and right upper pulmonary vein, which face each other. Between them there is the descending thoracic aorta, and the spine here is a vertebra. So this portion of the left atrial wall is fixed. And there is also systolic expansion that you can see longitudinally here in a two-chamber view, anteriorly and inferiorly. And now let's look at the relation between the left atrial reservoir function during ventricular systole and ventricular stroke volume. The normal reservoir function, the normal reservoir expansion of the left atrial area is 60% or more, like you can see in panel A, where we have a patient with coronary artery disease but totally normal function. And you see that there is a normal indexed stroke volume of 45 milliliters per square meter. Notice the expansion of the left atrium, normal expansion, the normal descent of the base toward the ventricular apex, and the fixed superior left atrial wall towards the spine, as we have said before. There is also expansion of the interatrial septum toward the right, and look at the expansion here of the lateral wall, laterally. And now look at the middle panel. We have a patient with ischemic delayed cardiomyopathy with normal filling pressures, but with a significant reduction of ejection fraction and initial reduction of the stroke volume index. The reservoir function, the reservoir systolic expansion of the left atrium is also clearly reduced if you compare it the patient with a normal ejection fraction and normal stroke volume. Look at the descent of the mitral annulus, which is quite reduced compared to this normal descent here, and look at the expansion of the interatrial septum, reduced, and the expansion of the lateral wall compared to the patient with a normal stroke volume. Here the stroke volume is 37 milliliters per square meter. And that look at the patient in panel C, which is the same patient as in B, but during an acute episode of heart failure. with a severe reduction of ejection fraction, reduced compared to the baseline evaluation, and further reduction, a severe reduction of stroke volume index. Now look at the systolic expansion, the reservoir expansion of the left atrium. It's practically non-existent, it's fixed. There is no movement of the base of the heart, no movement of the interatrial septum, and almost no movement of the left atrial wall. So we have seen here progressive reduction in stroke volume and progressive reduction in the reservoir of an expansion of the left atrium. A key concept here is the link between the longitudinal function of the left ventricle, which pulls the systolic descent of the cardiac base, and the reservoir expansion of the left atrium. They are linked. Summarizing, the ventricular and atrial function are connected during ventricular systole. A ventricular ejection through left ventricular longitudinal function enhances left atrial diastolic reservoir filling. And atrial filling on itself is a determinant of left ventricular stroke volume, since the blood that fills the atrium during atrial diastole or atrial reservoir phase is the same that then is ejected in the next systole into the aorta by left ventricular systolic function. So, in a careful evaluation, when we are at the apical views in our echocardiographic examination, allows you to qualitatively and rapidly assess left ventricular preload, the and diastolic volume, global systolic function of the left ventricle, the ejection fraction, longitudinal function of the ventricle by the systolic descent of the cardiac base, stroke volume also by looking at the atrial diastolic reservoir filling or reservoir function, and also determine left ventricular filling pressures, since the filling pressures are inversely related to the left atrial reservoir function. We have talked about this before when we have seen the initial qualitative evaluation of left ventricular systolic function in the parasternal long axis view. This is the two parasternal long axis views in a normal subject on the right panel, and in a patient with dilated cardiomyopathy on the left. So two different examples of atrial systolic expansion: a normal atrial systolic expansion along the anteroposterior axis, seen here with M mode, and a very reduced anteroposterior systolic expansion of the left atrium along the anteroposterior axis. Besides, so you can evaluate here both the dilatation, the dimension of the left atrium, dilated here, normal here, but also the expansion of the left atrium during the reservoir phase. And these are the apical images here from the same patient of the previous slide with dilated cardiomyopathy. Again, look at the apical view, the four-chamber view of the left atrium. No reservoir expansion of the left atrium during atrial diastole, which is superimposed on the ventricular systole. The base does not descend, no expansion of the septum, no expansion laterally fixed superior wall, and the VTI here of the LVOT is very reduced, 6.2 centimeters, with a extremely reduced stroke index for almost 15 millimeters per square meter. Our pulse Doppler's profile of transmitral and pulmonary venous flow contain much more information than just the peak velocities or the ratio or deceleration. It is important and very helpful to recognize all the available information in a Doppler flow profile, especially when we're talking about stroke volume. In panel A, we see an apparently normal transmitral flow profile, EA/1, normal deceleration time, but this in fact also reflects an increased stroke volume. an increased stroke ejection volume, due mainly because of this very large velocity time integral of the E wave. Now, stroke volume correlates with the magnitude, with the VTI, the global VTI of transmitral flow. We have seen that before because we can calculate stroke volume through transmitral flow. And generally speaking, even if we don't measure directly the annulus, the mitral annulus, the velocity time integral tends to correlate with stroke volume, especially the prevalent, almost always prevalent E wave. This is, of course, qualitative evaluation. The quantitative evaluation of stroke volume at the mitral valve level should be done at the annulus level, as we have seen before. Now, compare the transmitral flow profile in panel A with that in panel B. In panel B, we see not only a marked prolongation or relaxation, classical prolonged relaxation profile. We also see a marked reduction in the duration of filling compared to A. A very reduced filling time and a very reduced velocity time integral. The E wave has almost disappeared, and this corresponds to a reduced stroke volume of the left ventricle. In panel C, the pulmonary venous flow profile with a systolic wave and a diastolic wave and a small reverse wave. This pulmonary venous flow profiles reflects a normal stroke volume. The prevalent systolic wave reflects a normal reservoir filling of the left atrium. The systolic wave is the systolic reservoir filling of the left atrium, whereas the diastolic wave relates to flow that goes directly from the pulmonary veins through the atrium and through the open mitral valve in the left ventricle. This is early rapid filling of the left ventricle. As a matter of fact, the systolic wave of pulmonary venous flow depends on three factors. One is left ventricular stroke volume, as we said before, left atrial reservoir function, which is linked to stroke volume, and left atrial pressure also. An increase in left atrial pressure will determine a decrease in the systolic reservoir filling of the left atrium. Indeed, left atrial expansion during the reservoir phase depends on both stroke volume and atrial compliance, and the compliance of left atrium correlates with increase in left atrial pressure during left atrial chamber filling. So a reduction of the systolic pulmonary venous systolic velocity time integral will either suggest a reduction in stroke volume or an increase in left atrial pressure, or both. What will allow us to distinguish between these two factors will be also our quantitative analysis, of stroke volume in parallel, as we have discussed in this talk, but also of the analysis of diastolic function, as we have discussed in the other talk on this channel about the echocardiographic analysis of left ventricular diastolic function. This table dates back to the mid-90s. It's from Professor Schiller's group at the University of California, San Francisco. It is still valid today, and it shows how to quickly obtain an integrated estimate of a patient's hemodynamic status during a complete echocardiographic examination, low technology echocardiographic examination. We are in the mid-90s, so we cannot estimate left ventricular relaxation with tissue Doppler. But the parameters listed in the table are all routinely collected during the complete echocardiographic examination. We have the ejection fraction, and when you do ejection fraction, you collect also end-diastolic and end-systolic volumes, and as we have said before, the end-systolic volume is roughly an estimate of left ventricular contractility, whereas the end-diastolic volume index is the best estimate we have of preload. And also we have said that if we look at the LVOT pulse Doppler integral, it is an estimate velocity time integral, it is an estimate of the left ventricular stroke volume. And then if you add to this the transmitral flow and even the pulmonary venous flow, you can have also a rough estimate without using equations of the diastolic situation, both relaxation and compliance. So what you obtain here is that if you put together, you integrate these numbers, you can estimate quite reasonably a normal hemodynamic status, increased output, hypovolemia, moderate to severe systolic dysfunction, and cardiogenic shock. So in a normal subject, the ejection fraction will be above 50 to 55. You will have an end-systolic volume index of around 18 milliliters per square meter. The preload will be around 55 milliliters per square meter, and your LVOT velocity time integral will be 15 to 20 centimeters. And then in increased output, your systolic function will either be increased or be stable, but you will have a reduced end systolic volume index because of increased contractility, and most stable end diastolic volume index and increased LVOT velocity time integral. In hypovolemia, ejection fraction will be increased, the end systolic volume index decreased, but also the end diastolic volume index, and you will have a decreased LVOT velocity time integral with an increased heart rate, and then so on with mild to moderate severe systolic dysfunction, way down to cardiogenic shock. And this is the end of video number 4 of the echocardiographic analysis of left ventricular systolic function. Please proceed now to video number 5, which will deal with the non-invasive estimation of left ventricular contractility and longitudinal function. And you are on the Echocardiography channel, a channel for cardiologists, sonographers, but not only, a channel dedicated to echocardiography in real-world analysis. And see you in the next video.